Put your finger in front of it. I think we want to rezone it now.
All right, I think we're going to go ahead and get started. I want to thank everyone for coming out this evening to our event entitled Restoring the Doctor-Patient Relationship, Models in Alternative Practice. We're very delighted to have representatives from the direct practice care, or direct primary care community, and the, I know you don't like it being called Concierge Medicine, right, Nick?
I don't mind.
No? What's the other term that is used now?
Boutique medicine.
Boutique medicine, or concierge medicine. So we have representatives from different models of these alternative practices, and we'll get a chance to ask them all different questions. For those of you who don't know me, I'm Prayus Taylor. I'm the president of the Medical Society of Delaware. I am a practicing nephrologist with Nephrology Associates. I grew up in Delaware. I've been in practice about 12 years now. Certainly I see the difficulties we have in maintaining our traditional practices with respect to time, with respect to reimbursement, just with respect to the fulfillment that we get out of seeing patients on a day-to-day basis. And so it's always great to hear about people who are doing things differently, and hopefully we'll get some insight from them. So without further ado, I'm going to ask each of our panelists to introduce themselves and just say a little bit about their practice, and then we'll get into some questions that were proposed by members of the Medical Society through a survey that we did a couple weeks ago.
Hi there, I'm Beth Krenzely. I'm an internist in Middletown, Delaware. I've been in private practice with a partner for the past 13 years, and about 6 months ago, I transitioned my practice, left my partner, transitioned my practice to direct primary care.
My name is Kimberly Nalda. I'm a family medicine physician, and I've had my own direct primary care practice for about the last year and a half, which I started from scratch. So I didn't transition a practice, I began it from scratch. The practice is called Rekindle Family Medicine on Kirkwood Highway.
And I'm Christina Bobelski. I landed in Delaware after doing residency at Christiana, and went through working for private practice as well as a hospital-based family medicine practice, and decided, you know what, life would be better. There's a better way, and so opened up direct primary care practice about 2 years ago in Middletown.
I'm Nick Biasato. I'm former president of the Medical Society. I've been in practice for 37 years as a solo practitioner, never had a partner. I'm happy to say I survived to this point. But I have been getting up in years. I'm 66 years old. I wanted a life. I had 4,000 patients total, and it was chaotic in my office at times. It was, I would see 40, 45, maybe 50 people a day. Always running back from room to room, praying I never missed anything. And I realized that this is just not for me. And I did not want to join a practice or take on a partner, because I always wanted to be my own boss, which is what I wanted to be primary care. I wanted to be my own boss. I wanted to treat my patients and hopefully make a decent living and have a life. Seeing 40 to 50 people a day just gave me none. I used to go home exhausted. My feet were pounding. And that's about it. Eat dinner and sit down, maybe watch the news and go to bed. Weekends were call after call because I remained on call 24/7. And I was approached by a physician who was in the MD-VIP program, and he told me about it. I said, this sounds too good to be true. He said, no, it's true. And I was taken to their MD-VIP's headquarters in Boca Raton, which they showed me their organization, how their organization worked. I was impressed by it, and I said, it's now time to do it. And the only thing that I could say that was the hardest thing about making the transition was leaving people that I had been treating for so many years. It was heart-wrenching at times. But they understood, because they saw what I went through when I understood how they felt. And, you know, I did the best I could to make sure that I got them a good doc out there in the community that would see them in one place. And that's where we're staying.
Thanks, Nick. So I'll just mention to you that Dr. Nalda created a handout flyer on what direct primary care is. This answers some of the questions that were proposed to us on our website. The other thing I want to mention is we're broadcasting live on Facebook right now. We're experimenting with that for the first time here, but just to allow more viewers to participate in the conference today. So Dr. Biasados had a chance to tell us what the main factors were that drove him to transition to a concierge model, if you will. But I'd like to hear from the rest of the panelists as to what were the main factors that drove you to go to a direct care, primary care model.
Well, I think we're all familiar with the time pressures in primary care and in specialty care. I really like to know my patients well and delve into the medical problems they're facing and use the biopsychosocial model in the way that I was taught in my training. And you cannot do that in 7 minutes. It was just insanity. And as my practice sort of grew and maxed out in terms of numbers, I really just felt like every day I was, I understand your mention of the worry about did you miss something, but I would also feel like I was slightly letting each patient down every encounter. And that was like just drops on a stone, just chipping away at myself, my integrity, and it became unbearable to me. And so I started, I knew Christina, and I had been watching, the changes she was making, and then she introduced me to Kim, and I feel like they saved me. They got me out from under that drip. And so the direct care model, it makes sense, and it works, and I'm excited about it. I went to a conference in Kansas City last year before I transitioned. Have you ever been to a conference full of a room full of doctors that are happy and excited and just, bursting at the seams with energy? Most of us probably say no. So it allowed me to save my career and stay in medicine and restore my sense of integrity and my passion and love for medicine.
So my prior practice, I started with them because I wanted sort of a good work-life balance. So I started working with them Monday, Wednesday, Friday. It was a very good balance in my life. I was very happy. And then our practice got purchased by Humana. And Humana then said, nope, you can't work your preferred schedule, you're going to work my schedule. And then they started saying how many patients we needed to see per day. And they started saying, you're not coding high enough, you're not billing high enough, you're not ordering enough x-rays, you're not seeing enough patients. They just kind of started whipping us to work us harder and harder. And I ended up, at the end of it, patients were waiting 3 hours in the waiting room to see me for 10 minutes. And by the time I went in to see them, they were angry, they were hungry, they'd missed their kids at the bus stop, and I just felt like I was basically like abusing patients in this system. I mean, I couldn't help it, and I just spent my whole day apologizing and saying, I'm sorry for the way that this is, and I felt like I was giving terrible care, and it was really heartbreaking for me as well. And I lost that balance. I was always doing notes at home, I was really overwhelmed, and I just felt like I wasn't serving my patients well, and I wasn't serving my family well. And so I started researching the options, and I ran across this model called direct primary care. And I reached out to one of the pioneers of direct primary care. His name is Josh Umber, and he runs a practice in Wichita, Kansas called Atlas MD. And Josh, within an hour of getting my email at 10 p.m., and by 11 p.m., he had sent me back an email with a reading list and attached a file folder that said, here's my contract, here's my lawyer, here's my list of things I ordered for my practice, here's all the information that you need, freely given, because he believes that rising tides raise all ships. He believes the success of the movement depends on the success of the individual practices. And so having that kind of heart really gave me insight into the people that are part of this movement. And so I kind of researched it, and then I took the plunge in January of 2016 and have built my practice up from scratch, which has definitely had its own challenges. But I now have the work-life balance that I've always wanted, and I I now am taking much better care of patients. Patients are loving the experience. They walk into my waiting room and they are relaxed and they have the time and they receive an hour's worth of consultation and they are leaving much better than they began. So it's just been a really fulfilling process, and I've met tons of wonderful people along the way. But I really do feel like what Beth just said, I feel like we have found a way that is wonderful and exciting and works, and I want to be able to share it with everybody. We feel like we are in a lifeboat, we want to toss you life preservers, like everyone come along because we are so excited about this. And so if there's any way that we can be of service to you, please ask us directly, specifically, reach out to us directly.
I think my story is probably very similar. I had said before that I had been in a private practice here locally, and then also actually reached out to the hospital down south and said, hey, I want to do something different. I want to open up a practice, but I don't want the financial responsibility. I thought that would be a different type of step that would help me, and I realized the hospital really doesn't know how to run a primary care practice in terms of cost, in terms of, kind of going through the steps of what I needed as a primary care. So about 3 years ago, I guess, I said, you know what, there's a better way. I found myself just wilting. I came out of residency, I was ready, I was excited, and then suddenly, all of a sudden, everything started just not going the way I wanted it to. I love what I do, and just like him, I wanted to stop apologizing to every person I went into to say, oh, I'm so sorry, I'm a few minutes later, I'm so sorry. I wanted to be able to spend good quality time, have that long-term relationship. That's what I was trained for. And so what I ended up doing is just kind of seeing what was out there. I looked at some of the typical concierge practices. I looked at direct primary care, and I kind of combined them. I consider myself more of a direct primary care doctor, and just so that you all have an understanding of the difference, is that direct primary care for a monthly fee, usually, membership includes everything in that office, whereas with concierge, patients still are being charged their insurance, or billed to their insurance, as well as co-insurance or co-pays. So a little bit different in that sense. So anyway, I kind of created a bit of a hybrid, and it has been wonderful. I work 3 days a week, and I am able to have a great practice. I'm able to volunteer on the other days. Patients are so respectful of when they call me. I'm on call 24/7, but I'll tell you, it is a joy to practice. It really is. All my patients are a medical family, and my appointments, just for a typical appointment, is 60 minutes. I know that's unheard of, but I really get to spend quality time, because I really feel like if you have the time to spend with the patient, they're going to tell you what's going on. They might not say, I've got rheumatoid arthritis, but being able to have that conversation, that relationship, they will tell you in so many words. And then usually my physicals are 90 minutes to 2 hours. And even if we're not talking medicine the whole time, we're developing that relationship. And it really is an absolute joy to practice this way.
Thanks, Christine. I think that's great that you're giving us a nice perspective about why you entered this field. I think there were a lot of questions posed, and I'm probably going to, do you have a question that you'd like to ask
I was
right now?
just going to ask if we can ask our questions now or leave them to the end. How would you like this to be interactive?
We have questions. I think I'm going to try to leave some time at the end for questions that you may have, because we may be asking the same questions. I have a number of questions from our membership that I'm going to pose to them, and many of these may answer the questions you have. So can you save them until the end? And that way we get through as many as possible. Okay. And this doesn't, everyone doesn't need to answer this, but maybe one from the direct primary care side and one from the concierge side. Can you describe your typical patient? What are their insurance situations? Do they have a lot of health issues? Do they have few health issues? And lots of meds, few meds?
Let me take it.
Go ahead.
My patients have been with me for 37 years, some of them, so I do know them quite well. I still take insurance. However, what they get for concierge medicine for their fee is we do a fantastic soup to nuts physical, head to toe, nose to toes, I call it. We do vascular other studies in the office. We do lab work in the office, and we send it out, that's part of their fee. We do pulmonary function, we do EKGs, we do hearing, we do vision screens, we do the whole 9 yards. And then that's done generally by a medical assistant, gets all the information and data for me, and then 2 weeks later I sit them down and we go through a complete history and physical. I go through their testing results, set up a program for better health and wellness. Prevention is where I'm moving now more than just treat the illness. And so those 37 years of patients have become quite familiar with me, and I do know them well. But like I said, I went from 4,000 to 500 patients. Now, I guess those in primary care, solos, and those who might have done it, know it's a tough nut to crack, because insurers, in primary care, I think is, in my opinion, is probably the hardest of subspecialties, because you have to know everything. You have to know a little bit about everything, and you also have to be close to the patient and listen. And the reimbursement, as you know, from the insurers is lacking. They said, well, we're going to increase payments to the primary care physician, but to do that, we had to jump 5 more hoops to get that extra $5 or whatever they're going to add to their payment structure. Now, I don't mean to sound like I'm monetarily oriented, because I'm not, or I would have been a primary care physician. I might have been a surgeon or something in that regard. But it's nice to know now that I don't have to worry about these things. I have the equipment in the office that I need to do to find out what's wrong with the patient. They have an hour with my medical assistant, an hour and a half with me. When they come in now, I'm seeing 5 patients a day instead of 45, so obviously I do have the time to sit down and go, how's the family, what's going on, and we just chat. And I've gotten to the point, in some people I found things I don't think I would have found before. I feel that way. Maybe I would have, but I'm not sure if I would. I feel comfortable. I do house calls. I'm on 24/7 call. They have access to my cell phone. They have access to my computer through the internet. They ask me questions. I answer them. I have a portal with them. They show me their pictures for the rash instead of necessarily they couldn't make it to come in. We discuss it over the phone. And everybody seems to be happy, including the doctor. My staff is elated because they're not going crazy.
Hey, Nick, can I ask you a question?
Shoot.
So, in terms of, you had an existing practice that transitioned over. I don't know if you can tell me, but did you find that the patients who had more medical problems were more likely to follow you into your concierge model?
I would say 50-50, really, to be honest. I have still kept infants that come in because the infants are free to 26. There's no fee to the children of the people that come. I have young people in their 30s, 40s, and then I have very old people in their 60s through 80s. They've come with me because they've trusted me over the years, and we've developed a good rapport. I think personally, to succeed in this type of a practice, you have to have an established practice. You can't just start with square. But the established practice is for the people who know you and they'll sign on. I actually said I'm taking 500, more wanted to come, so we had a waiting list. But all in all, I think I've done them a service, 500 who stayed, and they've done me a service for staying. You guys don't take insurance, I see. I still do on anything else that they come in later with an amendment. I treat it, I bill it insurance. I do not take Medicaid any longer, which is okay with me. And that's, I hope I answered the question.
So I transitioned my internal medicine practice. I would say, regarding who the patient is, my practice now is a microcosm of my former practice. So I have healthy truck drivers that I might see once a year, and then I have, a Medicare patient that I might see every month. Everything from the super long med list to I only take a multivitamin or I take nothing. So it's not, there isn't a certain person that you could say this is the person that's going to choose DPC. It's anybody that wants that relationship with their physician, wants that access, and doesn't want all the hassle. So, and all different economic backgrounds too. There's a lot of myths out there, I think, about who would choose this type of practice, but it's a matter of individuals' priorities. I did offer discounts for my low-income patients. I do still take Medicaid. I have retained my Medicaid patients. So there are ways to kind of answering a second question about the patient population, but also speaking to some of the perceived misconceptions, I think, about who can afford direct primary care and who can't. So it's a really wide spectrum economically that's joined my practice. Definitely a wide spectrum, age and medical history and need. You know, some of my healthiest patients may come more often than some of my less healthy patients. So I think that we would say it really, the population is very similar to what you might attract in a regular practice.
So, the Medicaid patients you would bill like through Medicaid?
Yes. Yeah. And then to speak to insurance, most of my patients are insured. I right now only have a handful of uninsured patients. I think you actually have.
I have about 30% uninsured. I have a huge percentage of uninsured patients who are really attracted by our cash pricing because I tell them on my website what their labs are going to cost. I tell them on my website what their medications can cost. So I'm really upfront about sort of cash pricing that uninsured patients can expect. And I do give away 10% of my care, so 10% of it is basically needs-based, but I don't make them prove it, not yet. It just kind of go as my gut leads that I give discounts or I give care. So, you know, we have the right to make those decisions because insurance doesn't dictate to us what we can and can't do. But I have a good amount of uninsured patients. And in the beginning, I think we had a lot of patients who were rather high needs, who were kind of self-selecting for the practice. So I did have a lot of psychiatric patients signing up, you know, people who needed more counseling than others. And then I began to talk to employers and kind of get some of their healthy patients signed up for the practice. So now I have a whole panel of steel workers and restaurant workers and tow truck drivers and people that are at work all the time and don't really want to come in, but we can see them once a year and kind of keep their medical conditions under control, but they are not people who sort of overuse the system. So you can kind of balance out your patient population by reaching out to certain groups of people that you want to target. But we do have some patients who will self-select because they want to be able to call their doctor, text their doctor, email their doctor. But once they have been heard and you've gone through their list of 12 things that they have to tell you about, and at the end of an hour you say, do you have any questions? And they say, no, you've answered all of them. I got through everything. Once you've gotten to that point where you've actually taken care of the patient's issues, they become a lot less urgent and they stop calling all the time because you've heard them and you've taken care of what they need. So I think you've gotten most everybody kind of settled down into a nice routine at this point.
I think one of the other things that I do is if a person is interested, calls me up and is interested in the practice, I talk to them over the phone, tell them a little bit about what it is, and if they really are still interested, I say, you know what, come in for a private complimentary tour. I'd like to sit down and talk with you. And so really everyone does. And it's not just for the patient to get to know me. I want to make sure they've got realistic expectations. I want to make sure that if I'm there on an evening that I'm taking care of them, that I feel comfortable with that person. You know, and it works out beautifully. There have been people I have said, you know, I think you would probably be better served with XYZ type of doctor. So it is a two-way street, and I like that. It really is nice because it also, you know, I tell them, you know, I want you to have a wonderful medical home, and I want you to make a good, well-informed decision. There's never any pressure to join, and so I think really having that initial tour kind of solidifies the relationship if they sign up.
What's the average panel size for one provider in direct primary care? I think, Nick, you said 500.
But I see there's other guys in town that are only taking 300, and they're happy with that.
Okay.
I figured it, 500 would be more patients, and a lot of them want this study. So I had to go to the high, but I didn't want to go higher because it would defeat the purpose.
Direct primary care, does it vary? Is there a range?
It varies, but it's around about, I'd say 400 to 600, and at the high end, 800. I don't think I've seen a lot of practices that go above 800, but most people find that when they get to probably 600-ish, that they're pretty full and pretty busy, and you don't want to get beyond what you can deliver. So you don't want to get to the point where you're saying no to people coming in the same day or next day, you can't accommodate their appointments. So I think that's a comfortable level, because they say that on any given day, about 1% of your patient population will come into your office. So if you have a panel of 600, then about 6 patients will have acute needs that come up that day that may or may not need to be seen in the office. But
patient needs a referral to a specialist, how does that work in your model?
There were quite a few questions, I think I read the list about how insurance works. So when you have an insured patient or a Medicare patient, you can do the referral. The only groups of insured folks that you can't use, it's really difficult to make it work in direct primary care, would be HMOs. They have to have an HMO doctor by the definition of what an HMO is. So any other insured patient or Medicare patient, you send them to the lab with a lab slip, their insurance is billed. If you order an MRI, their insurance is billed. If they see a specialist, you can do the referral. So we have not had any problems with that. It does get harder when you have uninsured patients and you're trying to help them, accomplish all these different things. But we have negotiated cash pay prices or contracted prices with imaging centers, lab centers, so that you can help either your high deductible patient or your uninsured patient get things affordably. But I haven't had any trouble. I do the prior auths if they still need them. I haven't had any issues taking care of those kinds of things for insured patients. So they still use their insurance in many ways, but nothing in the office.
Have you experienced patients signing up, Medicare patients who all of a sudden fall in the donut hole? They've got maybe 4 months left in the year and are in need of healthcare services. Is that a time when you see an uptick in your membership or?
I think the donut hole applies to medications. It's a Part D phenomenon, correct? So,
But in order to avail of the Medicare.
Yeah.
So in order to avail, I should rephrase that, in order to avail of the pricing that you've obtained for your medications through your practice.
well, it works out well for them because if they fall in the donut hole and they don't have, now they have to pay full price for their medications. If you tried hard to keep them on generics, we can order. Kim and I both run pharmacies out of our practices, so we order wholesale medications, generic, non-controlled substances, and we can save our patients substantial money even when they're not in the donut. So, for example, a patient of mine, a Medicare patient, paid $74 for 90 days of generic Crestor, and I could order it for her for $16. And that was one of 5 medicines I ordered for her at less than what her Part D was covering. So the patients love it. They just love that. They have the convenience. If they need an antibiotic, it's right there. They come in and they walk out the door with $1 for their Bactrim for their bladder infection. So the in-house pharmacy is a great boon to direct primary care. But they still struggle if they're on brand medicines and they fall in that donut hole. There are ways to get around it, but it's hard. We can't really get them discounts on branded medicines in the United States. I'll leave it at that.
Is there a specific company you contract with for wholesale pharmaceuticals?
Yeah, you can order them from anywhere, but Beth and I both use the same company called Andameds. Andameds, you get an account and you go online and you order whatever medicines in whatever quantities from 30 to 1,000, and they get delivered next day. So, if a patient that I have is on a particular medication, I may try to stock a bottle of it for them so that when they come up with their refill request, I'll have a bottle ready. But for other patients, if I'm prescribing something that I don't have in stock in the dispensary, I can get it by the next day. And usually that's good enough. But I have a very lean inventory in my dispensary. I don't have a lot of excess. I order sort of the basics. But it's really, really a huge savings for patients when you give them their medications at cost, because we don't mark up medications at all. So patients can actually save the cost of membership in its entirety just in medication savings alone. I have several Medicare patients who save their entire cost of membership in medication savings. So that is a huge savings vehicle for patients. And it's not very difficult to run. And the oversight is simply by the Division of Professional Regulation. It's not by any pharmacy board because it's a medication dispensary in office run by a physician. And so there's not any hassle. You order the bottle of medicine, you count out 30 of them, you stick a label on it, you give the patient the information for it, and you give it to them. There's no complication. Very easy.
Great. So we've talked a lot about the benefits of these types of models in terms of patient care. That being said, how difficult is it to recruit patients?
I guess I can speak to that since I started from scratch. So I did not grow up in this area. it's truly starting from a blank slate. So I really kind of hit the ground running. I went to all these sort of networking groups and lunch groups and, physician groups, but also just regular sort of business groups. And I made a lot of wonderful contacts. And at this point, I have grown sort of linearly up till now, but I'm hitting sort of the exponential part, which when word gets out and people are talking and your patients are advertising for you, then you hit this traction point where I no longer need to go out and tell people about it because my patients are so thrilled with the service that they're getting and so thrilled with their results that they are going out and telling everybody. And I have a great referral program. So if a patient refers another person to us and they stay for 3 months, we give them a month for free. So that's pretty generous, and patients love that, and they're happy to spread the word. So, and I think social media is a huge way to advertise for free. So we have a Facebook page, and patients will review us on the Facebook page. I probably could do more with my Facebook page if I had the time, but it does kind of speak for itself, and patients get on there and speak highly of their experiences. So I think that does go a long way in terms of free advertising. I don't do a lot of paid advertising. In fact, I haven't done much at all.
In my situation, it was really my patients already established that stayed on. But what I'm finding out is now for a few people that have gone or could stay with me, we have replaced them from people who have talked to other people about the service and what they got. And they're coming in and I have a meet the doctor, courtesy review, we sit down, we talk, is this for you or is it for you? And they decide at that point whether they want to sign on or not. And the ones I have done that for have signed on, so they must appreciate the service.
About retention, a lot of times, sometimes some people start a gym membership, once someone signs on, have you noticed a lot of, let me just ask you this, have you noticed a lot of attrition, or do people tend to stay with it?
You answer either of them all.
No, that's people stay on. I mean, I think as long as financially they can keep doing it, attrition has been very, very low. I think they feel that they found a great thing and love the fact they get just personalized medicine and really haven't seen too much attrition. And I've been open for about 2 years, so after that first year, I was like, oh no, let's see what's going to happen, but people just kept going on. So it's been very good.
I was concerned about that, but I haven't seen much attrition. I've lost patients to, succumb to disease, picked up others in place. But there are some that just don't stay, but I'm comfortable with that and I understand that. I still give them treatment until they find a new physician, whether they can put it on their payment or not. I can't handle that. But I do send them to physicians that have said they would get to my patients.
Are there any common reasons why patients leave a direct primary care or concierge model? Let's say aside from
money
money.
would be the issue.
Money.
Moving.
Yeah, moving's been the big way
That's
of,
the main one.
right. I think some people lose sight of the model and they say they're not coming in enough. And so, if they pay for a year's membership and they've come in one time, they may not end up seeing the value in that if they haven't sort of gotten full advantage of the membership. What they are missing is the fact that they have this continuity of care and they have a safety net in case anything happens. But I've had, literally only one patient in the last year and a half that kind of lost sight of the fact that we're there for them. And after they paid for a year, said, I'm just not coming in enough. So I think that's probably a reason that some practices lose patients if they just don't come in. But the only way that we really lost our other couple of patients is they moved away to college or to Philly.
Have you had to discharge a patient for overutilization or abusing your DPC model or concierge model?
No.
Not yet, no.
I've had patients who have no insurance who take the model for the fee, and they at least get what we can do for them. However, if I find something that need to move on further, I tell them, you better get some insurance for some of these services, stress, whatever. You want to put that out. But some of these patients have saved it in their health savings account, and they put, and the fee to me is very thought that it could be done through a health savings account. They stashed away enough in that health savings account to go for any extra testing that I may find for initial assessments.
You can also protect yourself a little bit because you have a contract with your patient. Almost every DPC practice has some form of a patient-physician agreement. And so, for example, in mine, I state that their membership covers their yearly physical and 6 additional visits. And I have not enforced that, and I have seen, in 6 months, I've seen someone more than that, but it gives me a little protection that I could say, well, you've exceeded your visits, and the way the contract is written, they would pay a per visit fee after that point. And I think Christina has something a little bit similar in her contract. I was advised by a lawyer not to offer unlimited visits because you can't necessarily deliver that, which sort of segues us into some of the legal aspects if you want to go to that. One of the things that you want to avoid with a DPC practice is suggesting or giving the health commissioner the chance to think that you're offering insurance. So you have to be a little careful about how your contract is structured, and there are definitely resources out there to help you do that. Delaware does not have legislation about DPC. Many states do, it's growing. Legislation kind of falls on 2 lines. There's the is DPC insurance or DPC is not insurance legislation that many states have now passed. And then there's the use of the health savings account. Right now, it's a little bit of a legal gray area, but in general, you discourage your patients from using the health savings account to pay the membership fee. The IRS does not look fondly on that. They can use their health savings account for other things. So, but Delaware doesn't really have any legislation pending. There's no one actively, I don't think, promoting any DPC legislation. There may be something happening on the federal level, but that, who knows? Nobody knows what's happening there. So.
Well, I can speak to that in MDVIP. It was established in 2001. And initially, our federal government was somewhat in opposition to it, saying that this was not a way to do things. They didn't find it a problem. It was Stark, one of our senators from California. Senator Stark was, a thorn in the sides of doctors for many years. And he said, they had a negotiation. They said, well, let's see what happens in a couple of years. And then the statistics showed that those members in the MDVIP community had less ER visits, less hospitalizations. The cost of care was probably significantly lower for members in the MDVIP community, and then Stark became a member himself. So the federal government has said it's okay. I have not had a hassle with any of the insurers, because I still take insurance, about the issue. And the legal department in this company takes care of any legal issues that arose, and I didn't have any. So that seems to be a non-issue with the feds. I don't think the state government has anything to say in that regard.
And I should tell you with HSA or FSA accounts or even out-of-network benefits, the way that I work it in my practice, I'm not sure if you all are doing it, but just that, the patient comes in for an office visit, they don't pay anything, but I do give them a receipt with a number on it. They say for a physical, $150, and then they can submit on their own that receipt to their health savings and flexible spending account. That is legal. And a lot of people do that. So if they use all of their visits, about a third of the cost of the membership fee really can be reimbursed through their health savings account. So it's nice.
There's also other types of concierge practices. You guys are not in that particular type. There are others in which the practices are accepting money from a patient, but they don't give them any special consideration for that. And that is, from my understanding, not legally acceptable. So when you have a practice like me, like I do, you have to offer them something beyond what would have been offered before. And that's what the fee is paying for, something beyond what they've done before. Others are taking, I hear in the community there's a few doctors saying, you give me a certain amount of money, you're on with me, but nothing else changes. They're still coming in, still building insurance for everything. There's nothing special that's achieved by it, no extra on-call stuff. So that's not copacetic.
You have to be very careful. I think all 3 of us have opted out of Medicare because there are kind of gray areas with Medicare. And the reason being is because just that exact thing, that you have to provide non-covered services. And there are so many covered services with Medicare that to go through the labyrinth of figuring out what that is and being legally in the know can be very difficult. So most of us, in fact all 3 of us, have opted out. very easy to do now, and we don't have to worry about it.
Medicaid was more that type 2 hour to the MDVIPs, because you know, Medicaid. Medicare, it's not been in any way, shape, or form a problem.
All right, so,
Bryce, when will we ask you, because it's a quarter, or almost a quarter,
Yeah.
seven.
so I'm gonna leave about 15 minutes for questions from the audience. But one that you may be interested in, Dr. Chodos, is, would this model work for specialists or other specialties?
I think it's beginning to. Did you want to take that one? I think it's beginning to. There are a couple of specialties who we know of. One of them is endocrinologist, who does sort of a membership-based monthly. I think some allergists are sort of starting to think about that as well. There is a surgery center that we are familiar with that actually does fee-for-service. So they do transparent pricing and fee-for-service. So they take payment directly from a patient without dealing with the insurance companies. And you can go to the Oklahoma Surgery Center website and see how much your shoulder surgery is going to cost, all included. $9,000 for a rotator cuff. There you go, and you fly to Oklahoma, including everything. Yeah, and so I mean, so it's basically, you know, there's transparency of pricing that is also part of a direct model. But some specialists are beginning to do this. Pediatricians are doing it, but I think endocrine and allergy are some of the ones that I choose. GYNs, yeah.
It really lends
Something that's
itself-
chronic and recurring. I mean, allergy and
Right.
endocrinology, people with hypothyroid, they're
I was just gonna say,
hypothyroid forever.
yeah, the membership model really lends itself to primary care. You know, they say primary care doctors can handle, 80–90% of what most people need, and it is typically low. These are not expensive things. A B12 shot, an EKG, a pre-op, these are all things that they're not breaking the bank. For specialists that do procedural things, I think it'd be a little harder to run a cash-based practice. They might do more of a hybrid. So say someone has a high deductible, they might prefer to pay cash and have a cash-based price. But it's more complicated, I think, for specialists. I don't think as many would succeed in a membership model, but it doesn't mean that there isn't room for direct pay and transparency in pricing, which is something we all want to see.
So we're going to open it up to questions from the audience. I think we've covered quite a few of the questions that were proposed by the membership, but I'll put them out. I'll get to you second, Dr. Chodos. She had the first question. Zana, go ahead.
I'll try not to hog this in. I've just got some very important burning issues, and we all work for a living. So if you're at liberty to discuss how much you charge, especially the concierge, because I looked at the MD VIP, and I know that they charge a certain percent before they take you on, they examine your practice to see if it's a feasible model. That's my first question. The second question is vacation time, and how do you explain, if you want to take a 2-week vacation, how do you explain that to your patients? Do you give them discount, partial month?
I guess the question is addressed to the concierge practice type of thing, I imagine. The fee is $1,650.
Sorry, 16?
$1,650. And that's in this area. Other areas, I imagine it depends upon the demographics of the area. But it's $1,650 here to join the practice. But again, that gives you lots of benefits for that $1,650, more so than you would get if you hadn't joined. The company does quite a good job in helping you out in enrolling your patients. 2 months prior to my startup date, when I was at 500, ready to roll at 500, they embed a person in your office. I first talk to the patients who come in, say, this is our program, this is what I think it's good, I think it'll be beneficial to you. And then they also screen the patient, talk to the patient, discuss it with them, answering all their questions that they need to know. And then at my startup date, I'm done, they leave, and we go. And we have regular meetings with their directors in the area. We set up little things like walk with the doctor down at the riverfront. I had a welcome for a 1-year membership, thanks for staying with me, and I had a party in the parking lot of my office. It was dump the doctor. I got dumped 20 times. Had 200 people show up for that. We had food, dancing, And your other part of your question was
How much do
vacation
they
time.
charge you for that?
They charge me. There's a percentage, but I don't know exactly what that percentage is. They do get a percentage of the fee. And the rest is dealt out to you twice a month, get a few checks every 2 weeks. Regarding vacation time, if I go down to Rehoboth or something like that, I keep my phone and I take it myself. If I'm out of the country like I was a year ago and cruised to Italy, the doctors and VIP covered my people. So we had all the arrangements, just to transfer, the calls to that doctor, he picked it up. Obviously, only 500 people, I'm not as busy as when I had 4,000. I will not get a call in the evening generally, very rarely. Maybe 1, 2 calls maximum on the weekends. But I answer them directly and I take care of the issues that arise. So vacation time is covered through another member of our group. And now I think there's 12, soon to be 14, so we'll have a bigger group. And I'll use 1 or 2 of them, they'll use me to cover when they go away.
How about if they need to be seen?
They're
like,
seen
They are seen
that day,
locally.
that day.
Okay. If you're on vacation, somebody else
The
needs to
doctor
see.
will see them that day, that's part of our deal.
May I ask the others?
Sure,
When
it
you take
works
time off?
very similarly. The 3 of us are 3 amigo doctor. We've kind of worked together, and it really is nice because it's the same thing. It's a collaboration. So, for example, I'm going away on a cruise in August, and Beth will be covering my patients in terms of phone calls, and if they need to be seen, they go into her office. There's no payment or charge. There's no charge to the patient. It is a mutual benefit. And we've done that for each other, and it works out beautifully. And in terms of costs, I know that was another question, just to give you an example, for adults in my practice, I base it on their healthcare needs. So the first level is for folks who are pretty healthy. That includes a full physical, gynecologic exam if they need it, and 3 additional office visits during the year. That is $65 a month. And then the second level is for folks who have a little bit more going on, like a chronic disease like diabetes. That includes a full physical, gynecologic exam, and additional 5 office visits a year. Have people gone over? Yes. Which I try to be flexible with folks. But I usually give them maybe 1 free office visit, and then they know, because it's in the contract, that if they go way above it, it's an $80 office visit straight up. And the nice thing about that is that they can just use their agency at that time. But it works out beautifully. Kids are much less expensive, either $20 or $30 per month, just depending if a parent signs up. But it includes everything, and that's what I tell the patients. That fee includes everything. So if I have to come in on a Friday and suture up your finger, that's okay. There's no extra charges. If I have to do EKG on you, no problem. Let's just do it. Because that's good medicine. You're putting your patient first. That's good.
Just make a comment about the vacation thing. In Sussex County, there really are no physicians doing DPC. And my practice is probably going to be the first. It's starting in July. But I kind of spelled that out in the contract, that there may be an occasion where someone out of town, they may need to seek services elsewhere, and then if they have insurance, then that would be through the regular insurance. I feel like that's what I had to do. I didn't know if you guys had any other suggestions.
It's all about setting expectations, and your patients, they want to love you, and they value you, and they appreciate you, and they understand that you're a human being and you're going to take vacation, and they call you on the weekend and they apologize for calling you. It's such a different relationship than when you're in that busy practice and you're getting tons of calls and you don't know half the patients you're speaking to on the weekend. But yes, you lay out the expectations ahead of time. I have a communication sheet for my patients so they know when is it appropriate to email versus when do they need a phone call during business hours versus when is it appropriate to call after hours. And the more you can communicate your expectations, the more they are accepting of them. So it's not a problem. If they have to go to the walk-in one day, they're okay with that. They know. You can kind of tell them, look, if you want more than that, you can go to the concierge because this is what we can do for for you as a population. So
One thing that I was going to do before.
I'm going to move on to some of those questions because we have a number of people that want to ask more questions. So Dr. Chodos, and then swing it over to Bibi. to see if there's any questions there, and I'll swing it back over here.
The question I have, and Dr. Biasotto was kind of to give some actual numbers. If you have 4,000 patients, and you had
No,
50...
not 4,000. I mean, total
No,
before I went into
but
it.
before, yeah.
Yeah.
And you had 40 visits, let's say you take the lower number, 40 visits a day. And now you have 6 visits a day. Okay, so we're talking about that's a little bit more than an eighth. So does that mean that you have to make 8 times as much funds from those 8 patients to equal the income? I'm just thinking about how expensive does it become, or what's the cost factor to multiply for the small number of patients to make up to come to parity with what you were getting before?
When I looked at this, and I looked at what I would do and how I would get it, the percentage of that I would get out of that 1,650, it came out to more than when I was.
I'm talking about with the patients. So if you are seeing 40 patients a day, you know, and you're getting paid X, how much you need to get paid from the 6 patients to equal X? Does that mean that each patient, each of those 6 patients is generating, basically like 7 times as much revenue? Because I would think that somehow something's got to give. If you now have 6 versus 40, that you'd have to make that much more money from each patient in order to equal the same amount of revenue, unless there's some other factors that I'm not considering.
Yeah,
So
there's a couple
how does it work
factors.
out?
There's a couple factors, but go ahead.
So one is reducing your overhead. So one of the things that I can speak to in our practices is we markedly reduce our overhead. So we don't need 5 employees per provider. We don't need billers, coders, schedulers, administrators. We don't need that many support staff. In fact, Christina has none, and Beth has 2, and I have 1. So we run a very small shift, which means we can keep our costs significantly lower. So that's why we can charge a lesser amount per month. But the other thing is that you're looking at fee-for-service versus a membership model. So fee-for-service, you are counting on volume. You have to see that high number of patients in order to kind of get reimbursed a certain amount. But with the membership model, you get paid the same amount whether they come in or whether they don't come in. And so you're not as busy. You still have the same number of patients on your panel, but you're not having to churn them out all day every day. And you're handling a lot on the phone. You're doing email visits and text visits and phone calls, and you're handling a lot of things outside of the office that you're not having come in because you don't need their copay and you don't need to bill their insurance company. So the workflow is really different.
I would think that the volume, the fact that you're getting a recurring fee, that must be what is like interest on a stock. So even when it's not moving, you're still getting a dividend from holding the stock.
It's
So
passive income, that's what it
It's
is.
passive income, and
It's a beautiful thing.
the reduction in overhead was tremendous. Tremendous. I used to do a lot of pediatrics more than I do now, and I don't know about you guys, but generally in pediatrics you take a pretty good hit on immunizations, and the insurers never even seem to equal what you're getting for it. So I'm doing a lot less immunizations. My malpractice has gone down. The cost of supplies in the office is tremendously reduced. So there's a couple extra benefits beyond just to get a fee.
how many employees do you have before versus
I
after?
had 4, I now have 2. With all the benefits you had to give them and all that, it was quite costly. Now it's not as costly, and they're not worth as hard.
So that's a counterbalancing factor.
Exactly.
Supply costs subsidized, or do you get a better deal going through MDVIP?
You can on some things, yes. And on equipment purchasing, a lot of equipment. There was a lot of, we use an impedance scale, which is a scale that can, tell us body fat mass and muscle mass, and I use it. And then that was a gift for MDVIP. It's a little expensive at the street, but it was a gift.
So I'm going to swing over to BB. Any questions?
Can you hear me okay?
Yes, we can.
Can you hear me?
Yeah.
Okay, good. You mentioned immunizations. How do you handle that with kids? What do you do?
Me?
Yeah.
Any
Do you
immunizations?
offer immunizations?
Yes, we still offer immunizations. I just don't have to buy tons of them anymore. The infants that I have in the practice, I still give them all their immunizations, just like I would prior. And I just don't buy a large supply of them anymore because I don't have that much
And for me, even though I'm family medicine, I'm trained to see from itty bitties to not so itty bitties. I actually limit the practice to 8 and above. Do I have 5 and 6-year-olds? Yes, but that way I don't have to keep the immunizations on hand in the office. And it's very simple. Go to Walgreens, Rite Aid. It saves a tremendous amount of money and headache, I'll be honest with you.
We use the health department for our immunizations because patients paying cash for their immunizations for kids is not going to work. $250 for a Tdap, it's really quite hard. So we send them to the health department, and we're perfectly happy to take care of our patients.
Yeah, I'm internal medicine, so my adult immunizations they get them at the drugstore.
Anything else from
Any
Vivi?
idea? Yeah, any idea how we're actually in a group? Any idea how DPC works for those in a group, or does it work?
It's a little challenging, I think, because there are some groups, but they're pretty small. DPC seems to lend itself a little bit more to smaller groups. Financially, to transition a large group, it's going to be tight. You guys might have more trouble bringing your overhead down, but it can be done.
It can be. The one thing you also need to be careful of with DPCs and large groups is who is accepting Medicare and who isn't. And there's a lot of kind of legal aspects you need to look at, especially if you're cross-covering someone and you have opted out of Medicare and they have not. So it's doable. You just have to find a way.
In the concierge model, it's a little different. Say the 5 of you are partners. 1 or 2 of you could go the concierge way, and all of the patients that you have accumulated under your care can be split into the other 3 people if they don't go. So some practices have 1 person has transitioned and the other 4 has not. And there's 1 practice in mind that 1 transitioned, then 2 years later the other transitioned, and so on. And it left the last 2 guys with a large burden of patients, and they finally also opted to do the same transition. So that's an option for you guys in that regard.
I'm going to come back here to Dr. Osmani.
I'm Panelist. I'm a solo cardiologist. I commend you guys for staying in practice, not quitting. We need good primary care doctors. I feel on the same page you guys are. My interest is that I'm looking to partner with a concierge or DPC practice down at the beach, kind of looking at cardiovascular prevention and wellness. My flip side of the question I always worry about is maybe to Dr. Piosada, we have a lot of patients, and psychologically we give up these patients. But what do we do with these patients? As a cardiologist now, I'm starting to manage COPD, diabetes, and my phone lines are inundated. My primary care doctor quit. You sent me to him, and now he's MDVIP, which I like the MDVIP concept, don't get me wrong. But I don't know what to do with these people. I can't find them doctors. So what have you guys done, or what do you guys advise? Is there a list of the Medical Society of people who are looking at traditional service?
In my case, I was concerned and made sure that those that left would have good care after they left me. And a couple ways we did that. St. Francis embedded a physician on the 3rd floor of my building, knowing I was going this route to take my overload. That was one. And I spoke to about maybe 8 or 9 doctors in the area and asked if they would take my patients, and they agreed they would. I gave them a list. I do pediatrics, so I had 2 or 3 pediatricians who took it, and I do pain management, so I had some pain management doctors who agreed to take patients who left me and needed pain management. So I prepared for that. That was all circulated to them, what they decided to do. We discussed it with them all, and the majority of them went right upstairs to the doc at St. Francis embedded. Now, in your particular case, I mean, would you be able to treat APD? Would you be able to treat that I know COPD and cardiology, but how about, Lancet Boyle or something like that, you know what I mean? No offense in that regard. So you've got to have some kind of way to give them the service that maybe you're not trained to do, or you really don't want to do because you're specifically.
Yeah, our concept will be a little bit more integrated medicine, cardiovascular prevention, fee for service.
Okay.
It's a side concept, but I'm kind of worried about a lot of you guys went to MDVIP, which I think is great because you're still here, you're providing great care, patients are happy. But we get inundated with calls and what to do with these patients. If 10 or 12 docs went to MDVIP,
make young students and residents interested in primary care, where they can have a wonderful, satisfying career that fulfills their dreams, for themselves. And I will only speak for myself. I would possibly have left medicine, which made me incredibly sad because I love medicine and it's my calling. And I was at a point in my practice that I would have left altogether. So I had to get my head around saying goodbye to 2/3 or 3/4 of my practice. I gave them that list of physicians, and they're all fine. They all have someone, but it kept me in primary care, and that's where I belong. So there is always change is painful, and transitioning practices to DPC and pushing the DPC movement does come with some difficulties, and that's one of them. But to me, it's going to save primary care. It's going to make it a viable career for somebody, and that far outweighs the short-term pain that we're going to have from having to make those adjustments.
These three ladies are much younger than I am. I am 66, and 70 is my date of retirement. I have 3.5 years to go. This is a great way for an older guy just to slow down. I'm so glad I'm not coming out now, as opposed to moving towards the end of my career. I had a calling for medicine. I love medicine. I'm also director of the Wound Care Center and Hyperbaric Center, Christiana Care. So that keeps my interest peaked in some really complicated cases, and it's fun. Maybe I'll do that a couple days a week after I turn 70 if I'm still around. But I see what they're saying. There's nothing appealing to coming out today in primary care. I teach a lot of students at the Wound Care Center in my office, students and residents, and I kept seeing, what are you going to be when you grow up, was my line to them, and they would say, I'll be a surgeon, I'll be this. No primary care? No, it's just, we come out of med school with a $250,000 debt. It would take forever to pay that debt down. Why would I want to do primary care? Well, I think primary care is a calling, I really do. Medicine itself is, but I think, as you stated, this is a way to keep people interested and possibly engaged in becoming a primary care physician. But again, it's limited panels. But if we get enough of the younger people coming out that say, hey, I want a limited panel, I'm going to be a primary care doctor, and I'm going to be a good one, I'm going to be able to take time with my patients and take care of their needs, then more and more people may go that route.
Who said 2,000 people was a good panel size? Where did that come from? We should be asking those questions. It didn't come from doctors, I don't think.
No.
I think it came from an insurance industry.
Sure.
And standards that we can't meet.
So we're kind of running a little bit over. I know that many of you may have questions. I hope we got to most of them. On the handout, I think there's contact information for the panelists. Certainly reach out to them, or if you have questions, you can send them to Medical Society of Delaware, and then we can reach out to them and post them on our website. One thing we have done for members of the Medical Society, if you haven't checked out the new website, please do. We have something set up there called communities. So we can set up communities for everything, and they're basically like group chats. So it's available to Medical Society members, but we set up a group chat for direct practice care, direct primary care, and concierge medicine. And you can go on that and pose your questions, and then you can get answers to those things from society members who practice that type of medicine. So another one of the upgrades that we got when we revamped the website this year, and it does allow for a nice ability to just throw out a question and get multiple different answers for it. I want to thank everyone for coming out. Certainly, I know some of you traveled from very far, and I appreciate you. Appreciate the folks at BB for logging in remotely, and hopefully you had your questions answered and found the session informative. So thank you very much.